اللي بنعتمد فيه على عين الطبيب لتقدير الاستينوسيس. ال AIQCT will give us objective quantification of the plaque volume. Second of all, possible impact on patient management. As we all saw in the cath lab, we have to understand that AI could change the management plan. Does the patient really need more invasive procedures? Third of all, incremental prognostic value. Instead of focusing on stenosis, we have to take more into this picture. We have to look at another assessments or values like plaque composition. And last but not least, impact on future guidelines. The results from the Confirm-2 registries, they are not just numbers, they're the potential blueprint for the future guidelines. So, without further notice, it's time to meet our guest speaker, Dr. Mirvat Alasnag. She's the first female interventional cardiologist in the Gulf. She's a fellow of the American College of Physicians. She's also a fellow of the American College of Cardiology, a fellow of the Society for Cardiovascular Angiography and Interventions, and also a fellow of the Society of Cardiovascular Computed Tomography. She's the director of the Catheterization Lab at King Fahd Ahmad Forces Hospital في جدة في المملكة العربية السعودية. She's also the editor-in-chief in the Saudi Medical Journal, TCT Plus Middle East Regional Director, and a CAI International Chair. So it's truly an honor to stand before such a distinguished figure, and we are humbled by her presence. Welcome, Doctor.
Well, thank you for the invitation and certainly the introduction. It's just always a lot of fun and very invigorating to be with younger generations. So I'm glad you did reach out, actually.
Thank you. It's now you want to share your slides?
I think so, yeah. So I'm going to go ahead and share if I can.
So stop here.
Perfect. So you can see my slides now?
Yes, we can see them.
So first of all, it was really good and refreshing to hear that we have a young group who are still kind of trying to decide on cardiology. But I know I'm biased, ولكن this is a very exciting field. It's always expanding. There's always novelty that's happening. And the greatest thing about what's happening is, it's not random. It is actually one of the most investigated areas of medicine, clinical medicine, is cardiology. You do see a lot of trials that come out in the cardiovascular space that really have shaped how we practice cardiology. And hopefully we'll continue. And certainly the topic that you chose, looking at artificial intelligence and how it can help us to quantify and hopefully prevent atherosclerosis. And that's where the confirmed trials come in. It's really exciting that we didn't have many centers from the Middle East. This is a global project. And I'm really excited to, our center was one of the few representing the Middle East. But before we move to Confirm-2, you need to kind of understand what Confirm-1 or the original Confirm trial was. And what the whole concept behind it. Why did we even seek artificial intelligence? Well, it's time to move away from eyeballing. And the reality is that if you bring X number of readers, CT readers, or cath lab operators, and you show them an angiogram and you tell them, what's the percent stenosis? I could give you a number, say 60, 70%. Somebody else will tell you, oh, probably this is 80%. A lot of it is just eyeballing. It isn't actual quantification. And so the whole concept behind these registries is that it helped us look at a lesion that you see here. So this is a cardiac CT. These are 3D images that you see on the left-hand side of the screen. And in the middle of the screen here, this is the left anterior descending artery. You clearly see a lesion, right? So the nice thing about the technology is that it allows you to be more objective and you're not subjective about what you're doing. So it's going to tell you the total calcium. It's going to tell you the percent of atheroma. And if you look at the lesion down here, the second patient, it's a different patient and a different LAD. The biggest difference is there's some calcium, which gives you a mixed plaque that can obscure what you're seeing. And So the naked eye may not be able to quantify the lesion as well. And actually, what you end up doing with artificial intelligence is you can even look at the non-calcified plaque volume and get it. So not just the calcified volume, the atheroma volume, but look beyond the limitations of our eyes and even the machine itself, where you get artifact and so on. And so CTA for decades, what have we been doing? We've really been looking at coronary artery disease and looking at the conventional risk factors. So there's diabetes and hypertension and hyperlipidemia and smoking and so on. But now we're looking beyond that. We're looking at function and ischemia, but even beyond that, we're looking at the CT is able to give us some anatomy. So we're looking at stenosis severity. We're looking at the burden of atherosclerosis, and we're starting to look at the phenotype. So what are the features of the plaque that make one plaque more vulnerable than another? And what are the findings on CT, the anatomic findings that distinguish between one diabetic and another, or one smoker and another? Why aren't they all the same? Not every diabetic has bad aggressive coronary artery disease, and some have bad aggressive coronary artery disease. So diabetes alone is not enough of a predictor. We've learned that. We've learned that CT and analysis of the CT, the anatomy, non-invasively allows you to risk stratify the patients further. And that's where the CONFIRM trial came in 2011. So this was more than a decade ago. So it was prospective, it was international, about 12 sites, 6 different countries, over 27,000 consecutive patients were involved. At the time, the standard of care was about 64 slice CT, and so that's what was done. They enrolled all patients who had any indication for a CT angio. And so symptomatic patients and asymptomatic patients were also enrolled in these patients. It was observational data, not randomized. And they wanted to look at these patients, follow them up, and look at adverse cardiovascular events. So how many mortalities happened, how many MIs happened, and so on. And they followed these patients up for quite some time, 2.3 to 5 years actually, at a later analysis that was published. And effectively what we saw is we've known for some time now that percent stenosis is a good predictor of mortality. So patients with severe stenosis can also usually have it portends worse outcomes. And we learned that CT is actually a very good gatekeeper. So a normal or near normal CT usually confers excellent prognosis with fewer intercoronary angiograms down the line. We've also learned that patients with more plaque, more stenosis, are more likely to require invasive angiography, more likely to be revascularized. And in patients with obstructive disease, invasive angiography was associated with a lower mortality. So what we ended up seeing from the CONFIRM trial, the original CONFIRM trial, that, as I said, it was over, they looked at 17,000 patients. So beyond the clinical factors, it required about 2,000 plus patients to validate it. And the best predictor was actually the number of proximal segments as well as mixed plaque, like the one I showed you earlier in the presentation. So the mixed plaque, having plaque that's both calcified and not calcified in a single patient, that was actually the best predictor of mortality. And proximal disease was a good predictor. And all of that forced us as clinicians to reclassify, re-stratify the clinical scores that we've tallied on these patients, whether it is a Framingham score or what have you. And so the most important thing that we learned from subgroup analyses of these huge database that we collected is that in asymptomatic patients, so about 7,500 patients who were enrolled in the CONFIRM had no chest pain, but they had a CT. And the CT findings, even in asymptomatic patients, were independently predictor of mortality. Now, a calcium score of 0. In symptomatic patients, a calcium score of 0 allowed us to determine, future events in these patients. And although a calcium score of 0 is not absolute, we still know that it was a relatively good predictor. Similarly, when you're stratifying patients by age or by sex, it didn't really matter. You still were able to predict mortality based on the CT findings. And the same applied to diabetes. So really, it had additive value from the CONFIRM trial. And so what it established is one, CT is a good prognosticator. The anatomic severity is independently predicting mortality across the spectrum of all symptomatic, asymptomatic, diabetic patients, and those with a calcium score of 0. We actually learned that plaque volume and plaque burden outperforms lumen stenosis in predicting mortality. And the gatekeeper for invasive procedures and revascularizations and so on was actually a normal CTA that showed, or near normal, and that was good. So we actually had fewer invasive procedures and less flow into the cath lab. And again, beyond, as I mentioned, beyond clinical scores, the CT played incremental or additive value. So what changed from the CONFIRM trial to the CONFIRM 2 era? So we're looking at the 2000s to 2015, and then now the 2020s. So one is initially we were looking at visual estimates, right? And there was a human factor. The stenosis per AHA segments, and you looked at, basically we were saying, oh, calcified, not calcified, mixed, and that was the extent of it. That was the best we could do at that time. But there was no real volumetric assessment. We didn't know how to deal with blooming artifact from a lot of calcium and so on. So AI enabled us to be more objective, to quantify it and not just eyeball and say 60, 70%. It allowed us to give numbers. So now we're talking real numbers. So coronary plaque volume, you're looking at, yes, calcified versus non-calcified, but you're also looking at high-risk features. And it allowed us to be more reproducible and more scalable. And all of that variation that you saw between one reader and the other immediately narrowed with the AI technology coming on board. And so the CONFIRM 2 trial was the next era, which was published just about 2 years ago. It was a huge trial. So compared to the CONFIRM 1, you're looking now at 35,000 patients. You're looking at 50 sites. And of course, we did look at, of course, it was based on AI, and there was a lot of clinical endpoints, hard endpoints that we were looking at. And so we looked at plaque volume, we looked at, again, calcified lesions, non-calcified lesions, and low attenuated plaque, because those are the ones that we consider vulnerable. And percent diameter that was no longer eyeballed. It was now an actual measurement that you're getting from the system. And we finally agreed on the definition of a high-risk features of any plaque. So when we're looking at spotty calcification, napkin rings, some positive remodeling, and so now we're all speaking the same language. It isn't that we're just seeing a lot of calcium and saying, oh, this looks like an angry lesion. No, no, no. That's not really how it is. In fact, when you think about it, calcium is a marker of chronicity. And so that rarely, calcium per se, rarely indicates that these are vulnerable lesions or vulnerable patients. And so the aim was to see if AI-enabled CT evaluation would allow us to predict major adverse cardiovascular events. And hence we move more towards precision medicine. Again, this was a repetition. We're looking at the percent stenosis, non-calcified plaque, as well as calcified plaque, 3,500 symptomatic patients. This was the original report or the interim report, 18 sites. Already AI quantified CTA outperformed this classical standard clinical risk factors for major adverse cardiovascular events. And this was presented on behalf of the CONFIRM 2 trialists at the American Heart Association. And why does it matter? Well, it matters because, as I said, AI allowed us to be more accurate, more reproducible, but allowed us to be more discriminatory. And that's ultimately when you want to do a test. So inshallah, soon your physicians, patients will come to you and you will start realizing that if you're going to order a test for a patient, your patient is going to want not just to know the results, but they're going to want to know you as a physician. What are you going to do with these results? And so if the results are ambiguous or you don't know what to do with them because none of the evidence that was published or presented has told you that it's discriminatory, that really works against you. The good thing about the CT-enabled AI is it's actually allowed us not only to be accurate, but to have a conversation with patients. And you know what I do is I actually put up the images and let the patient see them. And I explain to the patient, of course, not in too much detail, but I learned that when patients actually see their own images or they see مثلا their weight increasing, they actually see it. You show them the chart or their blood pressure going up, for example, or their hemoglobin A1C, pictures tend to speak louder and it suddenly registers with them. And you know, you explain to them, we're partners in this. I'm not alone. You as my patient, you're just as important in preventing cardiovascular events. And so you know you need to lose weight, مثلا, or you need to control your sugar because your hemoglobin A1C is actually going up. And likewise, it scares the hell out of them when they see these CTs and you show them these features.
So it improves compliance in a way.
Absolutely.
Yeah.
Absolutely. That's exactly what you want because, you know, you can sit and preach and advise your patients, stop smoking, stop smoking, stop smoking. But you really need to find something that motivates them to actually do it. But if every visit you keep telling them, oh, your weight is going up, oh, you haven't stopped smoking yet,
Yeah, they will not listen.
you
They will.
haven't achieved anything and you're just spinning in a vicious circle unnecessarily. So, what did the CONFIRM-2 trial establish? Well, one is that non-calcified plaque volume is a stronger and an independent predictor of MACE, more so than calcified plaque volume. So, we need to be very careful when we're interpreting this zero calcium. Two dominant signals, the percent stenosis and non-calcified volume, complement each other and they actually give you an incremental risk on CTA. We've seen that now with the published results. Once again, AI quantification clearly outperformed visual assessment. And I can tell you, for me personally, it just shortens the time you're spending with the CT and scratching your head and, you know, trying to change the window levels and so on with the CT to see, is this real or is this blooming artifact from the calcium that I'm seeing? And so again, as I mentioned, it allows us to be to deliver the appropriate therapy to our patients. So the CONFIRM versus the CONFIRM-2 trial. You're looking at the dates, but you're also looking at a much larger patients population. You're looking at multiple sites from around the globe, and hence it's more representative of global practice. And you can't just say that it's limited to, you know, sophisticated centers or certain parts of the globe and so on. Again, it allowed us to do plaque volume, and it's no longer just saying, oh, percent stenosis, etc. It's allowing you to use numbers that when I compare my patient to your patient, we're all looking at volume and something that's actually more concrete. And the strongest predictor was, yes, percent stenosis, but also plaque volume, non-calcified plaque volume. And ultimately, we looked at not just mortality and MIs in the CONFIRM-2 trial, we looked at a composite of major adverse cardiovascular events. So pretty much everything together. So selecting patients, it's well suited for symptomatic patients, again, across all spectrum of patients with a very good pretest probability. Asymptomatic patients have high-risk individuals with anatomy that's going to help us decide on the treatment plan for our patients. It's taught us to look beyond percent stenosis, so we're looking at total volume, high-risk features, and so on, and hence personalized therapy. So if you see two diabetic patients, irrespective of their hemoglobin A1C, but one of them you're seeing high plaque features, you know what you need to do in terms of their diabetes control, in terms of maybe even giving them anti-inflammatories, intensifying statin therapies, and so on. And avoiding unnecessary invasive imaging. You know, I do coronary angiograms and CATs and PCIs, and I actually think CTAs did not take away from my cath lab pool. Unfortunately, with the fast food chains and smoking and so on, you know, the trends in our part of the world is actually going up and it's not getting worse. And climate and its impact on health, we've seen that, pollution and so on. But what it's done is it's allowed me to clear up the cath lab space for patients that I know will benefit from my intervention, as opposed to just bringing all these patients and you just do diagnostic caths and you just eyeball their coronary angiograms. And it also allows you to monitor these patients, right? So you can, in principle, move away from something invasive, start your patient on preventive therapies whether it is lifestyle modification or actual like lipid lowering, anti-inflammatories, and so on. And you can look at progress if you do the CTs again. At this time, I don't recommend it. It's still giving your patient a load of contrast and radiation, but perhaps this is something for the future or for patients who are very high risk. And the good thing about it is a lot of sub-analyses were published. And this is something that I also enjoy, is to actually look at sub-analyses, for example, in women. And I wanted, and this is an area that's close to my heart. So we looked at, in the confirmed trial, over 3,000 patients, of whom almost 50% were women. And we looked at the plaque features, AI evaluated features, reproduced features, and we saw that we were able to do it, but it was actually even more predictive in women than it was in men. And so that was actually an interesting concept. So what do we need to learn? Like I've just spoken about these confirmed trials and really proud of them, but when you look at studies, you really need to have some critical appraisal and you need to gauge what the limitations are. So one is, yes, the scale was monumental. You're looking at thousands upon thousands of patients from multiple continents and multiple sites. And so it's really good and representative. It was prospective. So the good thing was this was not a retrospective analysis. So because it was prospective, we were able to do a lot of pre-specified analyses, looking at asymptomatic patients, looking at women, looking at diabetics, and so on. Again, the external applicability, looking at granular imaging. So you could actually segment it now because you're actually looking at an AI tool that's able to take a large volume of data. So 30,000 patients with all the segments of the LAD and circ and right and so on. So it's a huge database and they're able to do it for you in minutes. And we were able to look at these patients with hard clinical endpoints. So you're not just looking at, how many rehospitalizations these patients? No, we looked at hard endpoints like MI and death and so on. And the follow-up, I wouldn't say it's long. The follow-up was intermediate, to be honest. So we're looking at around 5 years, but we do intend to continue to look at these patients. But what were the limitations? What were the weaknesses of these trials, right? One, it's not randomized. So this is, at the end of the day, observational data with all the causal claims cannot be really made because of that. There's always some kind of verification and ascertainment bias that we have to be cognizant of. And mortality, especially all-cause mortality, dilutes some of the other cardiovascular events. So if somebody dies, you're not going to be able to see if there were, the risk of strokes or MIs and so on. And of course, there's always referral or selection bias, some confounders depending on the patients. So if patients have renal dysfunction, didn't end up getting CTs, etc. And of course, conflicts of interest. I mean, we have to mention it. This was, at the end of the day, vendor intellectual involvement. They were integrally involved in the analysis. But what we do look is that I don't want to get too much into the analytical assumptions. This is available if you want it for you to look at, but actually overall it tended to do well. They apply to symptomatic, asymptomatic patients, high volume centers all over the world, stable coronary artery disease, not really those with acute coronary syndromes. And so I'd be a little cautious about patients who are low risk, patients in whom there's tremendous calcification still or arrhythmias and you can't get a high quality study. Special populations, I'm not sure we had excellent representation, for example, from Africa or Latin America, for example. And we need to interpret this, which was essentially done for patients who are stable outpatients, and not confound it with other trials that were valuable as well in the CT space, such as PROMISE and SCOTT-HEART, that actually looked at acute chest pain pathways. And so that's a different area. But I think when we're looking at the total body of evidence, and this is hopefully what we're going to take away from it, is when you're looking at mechanistic trials that were early on, these were just mechanistic. Many of them were single center. Confirm our registries, so they're slightly higher, and we're looking at large prospective trials. The ones that are looking at, as I said, the acute ischemia pathway or I guess, ischemia trial didn't look at ischemia. It looked at stable patients and who had ischemia by MRI and so on. And so PROMISE, Scott Hart, and so on, these are randomized trials. Meta-analyses are pooled CT data, and there's several meta-analyses out there. And all of these ultimately inform the guidelines. So the guidelines are really ultimately what's going to tell us how to treat our patients based on this. Do I think the guidelines will change based on the confirm? Absolutely, although it's down here. But I think the evidence is very, very strong when we're looking at these patients. And I do believe that right now, when you look at the latest ACC guidelines on chest pain evaluation, for example, they've certainly upgraded the role of cardiac CT in these patients, and it's moved up. What didn't the confirmed trials look at? So the confirmed trials looked at what have I been talking about lately? We've been talking about anatomy, right? It was strictly anatomy. But there's more than that. There's physiology. There's the functional importance of a lesion. And so when you look at a patient like this, and you look at this is the left anterior descending artery, this is the angiogram of the patient, and this is the CT of the patient. And the same patient also had intracoronary imaging, like an optical coherence tomography. But you do see that the physiologic significance. So now I have a percent stenosis, or or I have more than one lesion, for example, and so on. How do I allow this to guide me to make a clinical decision? Because ultimately, you want to do a test that will help your patient. So when you're looking at two different patients, you're looking at a patient, for example, with focal disease. These are patients that we know will likely benefit from revascularization, particularly percutaneous revascularization, i.e. stenting. But someone with very diffuse disease, so you're doing a pullback and you're seeing that this is very diffuse, it really doesn't normalize anywhere early on. You know that these patients are less likely to benefit from spot stenting. And these are patients who will probably have residual angina post PCI. And so you likely will need to just put them on optimal medical therapy. And so that's the direction. And this is my guess where the next decade is going to be heading. It's going to be merging anatomy with physiology. And so when you're looking at an FFR CT, so CT, you see this is a patient with a circumflex lesion that you see by angiogram, and you see it as well by FFR CT. And the CT is going to allow you to look at it physiologically, but to also plan your PCI. It's going to help you decide the length and so on well before your patient comes into the cath lab. And so I do think that that's what the next era is going to be about. So my ultimate take-home messages for you about the confirmed trials is yes, anatomy of coronary artery disease is very important and very predictive, and it adds value to the conventional risk factors that we currently know. That was based on the confirmed trial. Confirmed 2 allowed us to quantify and to actually provide a phenotype for the different non-calcified plaques, which were again independently predictive. But once again, I told you that this was fantastic registries, and so it comes with its own limitations. And so we really need to be very careful when we're interpreting this data set, when we draw conclusions. And at the end of the day, you do need to individualize your decision making with your patients. So I'm going to stop here, hand it over back to you, and feel free to all the attendees if you have any questions or anything.
Thank you, doctor. That was really an inspiring and a comprehensive view on your study. And it's really like we're looking into the face of the future regarding cardiology. I already know that you said we are not ready yet for this to apply this to real clinical practice. So, what do you think is specifically still needed to apply it? Like,
So I think you very quickly you learn that medicine isn't, you don't practice medicine in silo or alone. You practice medicine as a cardiologist with your lipidologist, with your diabetologist, with your patient, and so on. So it isn't enough that we have the technology and that we're able to do these studies. It is important that the community, you have buy-in from the community. They understand the predictive value of CT. And at the same time, the infrastructure, the healthcare infrastructure, whether it's a Ministry of Health, whether it's a private sector, etc., is able to develop a pathway where there is no overlap, and you're able to not overwhelm the system with unnecessary CTs for asymptomatic patients simply because you want to risk stratify them. So I think that's where we are now, is we know the power of the CT studies that we're doing. We know that they can be predictive, but at this point in time, do we have the correct infrastructure? And are we adding a financial burden on the healthcare systems by saying, hey, let's screen all these patients? So I think we're not quite there yet.
Okay. Um, does someone have any question for our credible guest? Anyone have a question?
So how many of you are interested in imaging, cardiovascular imaging, whether it's CT or MRI or nuclear, just kind of a...
Personally, I am interested in it. Yeah, it's a fascinating field.
So I have to say, there's a lot of job opportunities with imaging. Uh, so if I'm allowed to just give you and your generation some advice, that imaging is an expanding field. So there are going to be tremendous job opportunities for imagers.
I feel like it's replacing a lot of the practices that are,
It is,
yes,
and really good really good imagers are hard to find.
yeah,
So that's why there's a lot of competition in areas like the cath lab. Everybody thinks the cath lab is glamorous, and so people are always running, and there's a lot of competition with the cath lab. But the cath lab, you are limited by the number of cath labs in the region that you are at. But CT, you're almost like a free spirit, and you can just jump around and do CTs everywhere. For example, MRI is a slightly longer procedure, but imaging, there's a huge demand for it. And so if you're looking for future prospects and so on, I strongly urge you to attend some webinars, meetings, and so on with advanced cardiovascular imaging. And you'll very quickly learn that it's an area that hopefully you'll enjoy, hopefully you'll add value to the field, but there's a lot of job demand and opportunities for it.
For sure, we'll consider it after this incredible session. It's really interesting how you integrated AI and how you kept on with the technology and the development of the technology and combine it with medicine. It's really interesting.
So artificial intelligence, I think the next decade is going to be about artificial intelligence. I do quite a bit of research as well, and I run a journal. And in the beginning, we were still learning about all these submissions that come to us, and we clearly know that it's AI supported.
Mm.
And, everybody was talking about regulating it, and very quickly we realized that, it's almost like the Industrial Revolution. So, when you go decades ago and people were like farmers and so on, were worried that, oh, are they going to come and
Yes,
take our
yes, yes.
jobs? And you realize they're not here to take your jobs. They're here to make your job easier. And so you quickly start to learn that you need to embrace artificial intelligence, whether you're looking at it in terms of CT, whether you're looking at it in terms of research and so on. So yeah, AI is something I think your generation is going to be better, much, much better than my generation at. And I think the tables will turn, and one day we'll be learning from you guys. So absolutely embrace it and run with it.
The bases, and we have to build on it.
Absolutely. And perhaps the only other piece of advice that I'll give folks who are here is think about research. I personally didn't start it except later in my career, because it wasn't really ingrained in our training and so on. But when you do research, you very quickly learn that you start to shape the field that you practice in, because investigators are the ones that give us the evidence that tell us how we should be treating our patients. So if you want to lead your field, you need to do research. And so that's something I'd advise you to do early in your careers. Learn how to do research, learn about methodology. And if there's an area that you're interested in, so if you're into EP, if you're into echo, if you're into imaging, cath, pick something that you're interested in and do the research there. And it'll quickly separate you from the crowds. So هتتميزوا if you're doing research, and that's what I strongly recommend.
Yeah. Honestly, most of our students, we're in the college, are really interested in research and we're pursuing it.
Excellent.
Yeah. But still, we have some limitations, some yeah, difficulties.
That's life.
That's life.
You
Yeah.
know, whether you're a student and whether you're a consultant and whether, I mean, there'll always be challenges, but I
Yeah.
think your generation is, inshallah, motivated, and I'm confident you'll take this much further, bismillah ta'ala. Oh, good.
Inshallah.
Rami's saying you guys have a research office.
Yes,
Fantastic.
we have in the cardio science division. Yes.
Fantastic.
So, does anyone have any question for our guest? Is there anything else you would love to add, Doctor?
Well, thank you for having me, and
You for agreeing to hold this session.
no, absolutely my pleasure. And do reach out anytime. Glad I got a chance to meet everybody, and I I tend to respond to these because I actually enjoy them.
We also enjoyed it a lot. It's an unforgettable session.
Well, جزاكم الله خيرا, and I hope يعني قدمت لكم شيء كده بإذن الله تعالى يفيدكم. And yeah, do reach out if there's anything I can do to help you. يلا بالتوفيق إن شاء الله.